Good afternoon. Thank you for the opportunity to present to the board today. We're speaking on behalf of the Spencer Regional Medical Center's Ethics Committee, and we're going to walk you through a maternal fetal conflict case that came through our hospital, the ethical analysis our committee performed on it, and the policy we're recommending as a result. Our team is Jesse Chung, Alicia Hagman, Daniel Hoskinson, and previously Ashwanza Rivers. The purpose of our presentation is to present an ethical analysis and policy recommendation on the management of maternal fetal conflicts when a competent patient wishes to refuse a medically recommended cesarean section at Spencer Regional Medical Center in the state of Irwin. Here is our roadmap to the topic of maternal fetal conflict. We'll start with the case itself and the ethical dilemma it raises. Following that, we'll look at who's affected and how their interests conflict. We'll ground that in the core ethical principles and in how courts have ruled on similar cases, as our fictional jurisdiction has no statute on this topic. From there, we will walk through the alternatives our committee considered, land on our recommendation, as well as providing the justification for it. We will close by addressing the objections we expect and what implementation will potentially look like. Maternal fetal conflict shows up any time a competent pregnant patient's decisions about her own body runs against a physician's recommendation aimed at protecting the fetus. It's not unique to cesarean sections. You'll see the same structure with blood transfusion refusals, chemotherapy during pregnancies, religious objections, and cultural considerations, as well as substance abuse. Our case today is a cesarean refusal, but the ethical framework we're proposing is meant to generalize this whole category of conflict. Here is the specific case our committee reviewed. A competent patient at a viable gestational age declines a recommended cesarean after fully counseling. Instead of stopping there, the disagreement escalates, the recommendation gets repeated at every shift change, and legal counsel and court authorization get raised, essentially as leverage. Nobody performed a procedure without consent in this case, but the process itself became coercive. That's the gap our policy is designed to close, not the outcome, but how the hospital behaves while the disagreement is unresolved. Why does Spencer Regional Medical Center need a formal policy at all? Two reasons. First, this case sits at a genuine collision point of core bioethical principles: autonomy, beneficence, non-maleficence, and justice. And reasonable, well-intentioned providers land in different places on it. Second, without a defined process, individual providers are left to improvise in the moment, which is exactly how we get the kind of escalating pressure we saw in this case. That produces moral distress for the staff, legal exposure for the hospital, and inconsistent care depending on who happens to be on shift. 6 groups of stakeholders matter here: the patient, who is the decision maker and must have their bodily autonomy respected; the fetus, who can't participate but has a real interest providers have a right to advocate for; medical providers, who have a duty to recommend the appropriate care warranted; the family, who operate as support persons for the patient as well as the fetus; the ethics committee, who facilitates a structured and standardized process instead of reactionary moments of care. And finally, we want to acknowledge 2 groups that are easy to overlook: patients from historically vulnerable populations, who research shows have been subject to coerced interventions at disproportionate rates; and the public and the institution itself, which bear real downstream cost when outcomes are poor. Our policy has to hold all of these in view at once, not just the first 2. These 4 principles, autonomy, beneficence, non-maleficence, and justice, don't all point the same direction in this case, and that's exactly why it's a genuine ethical dilemma and not just a clinical judgment call. Respecting the refusal advances autonomy, and we'd argue non-maleficence, because overriding a competent adult's decision is itself a harm. It comes at the cost to the benefits the care team was pursuing towards the fetus. Justice matters here too. Policy has to apply the same way regardless of who the patient is. Since our fictional state has no controlling statute, it's worth looking at how real courts have handled similar cases. Jefferson, in 1981, authorized a cesarean section over a patient's objection, an early example of favoring fetal interests. In Re AC in 1990, this is the case that is most often cited today. A court-ordered cesarean was performed. Both the mother and the infant died shortly after, and the case became a turning point towards emphasizing patient autonomy. Pemberton, in 1999, went the other way on narrow facts, which shows this area of law is still unsettled. The trend line, though, runs towards autonomy, which is consistent with where our policy lands. We looked at three options. Simply always honoring refusal with no process leaves providers to improvise, which is what produced the escalation in our case. Allowing Spencer Regional Medical Center to seek judicial authorization in exceptional cases conflicts with ACOG and AMA guidance and just reproduces the coercion problem in a more formal package. We rejected that outright. The ethics committee model is the strongest of the three. It gives providers a structured outlet for their concerns while keeping the decision with the patient. Its singular weakness is timing, which is exactly what our recommendation is built to solve. This is our recommendation, and we want to state it plainly. 3 commitments. First, never force. Spencer Regional Medical Center will not perform, seek authorization for, or otherwise compel a cesarean section over a competent patient's refusal, regardless of whether the risk is to the fetus, the patient, or both. Second, always counsel. Every refusal gets a real, documented conversation about risks, benefits, and alternatives. Third, consult fast when time is short. Full committee review when the clinical situation allows it, and an expedited pathway when it doesn't. That final point is a change in process and timing only. It never changes the outcome in point 1. Mechanically, this is what the policy asks providers to do every time. Assess and document capacity, provide real counseling, offer consultation, full or expedited, which we'll define on the next slide. Document the whole conversation, not just verbally, but written in plain language, preferably the one native to the patient, and continue providing care regardless of the outcome. Refusing the procedure is never grounds for stepping back from monitoring or support. This is deliberately simple enough that a provider can follow it under real-time pressure. This slide resolves the question our own instructor raised about our draft, so we want to be precise here. There are 2 situations, and they get different treatment. If there is an immediate life-threatening risk to the patient herself, hemorrhage, rupture, eclampsia, the team proceeds with standard emergency care without waiting on a consult, the same as for any emergency. But if the urgency is about the fetus alone, with no comparable threat to the patient's own life, the refusal is honored no matter how urgent the fetal situation is. We do not perform a cesarean over a competent patient's refusal for fetal indications alone, ever. The only thing that changes with urgency is how fast consultation happens, never whether the refusal is respected. Why do we think this is the right call for Spencer Regional, not just an ethically defensible one? 3 reasons. It's consistent with every relevant professional code we could find. ACOG, the AMA, and the healthcare executive's own code of ethics all point the same direction. It's honest about trade-offs. We're not pretending this eliminates fetal risk. We're arguing that the costs of coercion, including the documented history of coercion falling disproportionately on vulnerable patients, are worse when you look at the whole patient population rather than one case in isolation. And it passes a basic fairness test. Is the rule we'd want applied if we or a significant other were the patient? We expect 4 objections, and we'd rather name them ourselves than wait for the board to raise them. Fetal protection. We believe the evidence on coercion actually cuts the other way. Liability. Good documentation of informed refusal protects Spencer Regional Medical Center better than intervention does. Emergencies. Already addressed. The policy is built around exactly this coercion. family involvement, included by invitation, not by default, so it supports the patient rather than pressuring her. On implementation, the real cost is staff time for consultation and annual training. We think that's a reasonable and modest cost for the protection it buys the hospital. To close, we are recommending Spencer Regional Medical Center adopt the Ethics Committee model with an expedited emergency exception, never forcing a procedure, always counseling, and consulting quickly when time is short. It reflects current professional guidance, it's honest about its trade-offs, and it gives providers and patients a defined, humane process instead of ad hoc pressure. Thank you. We're happy to take any questions.